changes, we will not proceed with the surgery. Using the healthy person's vital sign chart as a reference, can our patient undergo surgery today?
Hi guys, it's Raptor here. It's your boy Raptor. But I'm gonna do a little series that I like to call Operate Now. Well, it's literally called an Operate Now game, but I mean like I used to do this on my old channel where I was actually called Raptor. So I am gonna educate you guys on how to be a surgeon. Well, you don't have to be a surgeon, but it's education. And no, I'm not a boffin. Alright, let's go. Pause this, read all that, you'll learn something about yourself. Yes.
It looks like surgery will proceed as planned. Take a moment to look at our patient's x-rays. Which knee do you think needs surgery?
Come on then, recruits. Which one do you think it is? That's clear. And not bumping, that one's bumping.
You're right. His left knee appears worn down and lacking cartilage, which is likely the cause of his pain. The nurse has begun prepping our patient for surgery by placing an IV needle in his right hand. Now it's your turn. Use the marker and write your initials on the proper knee to be operated on. This may seem silly, but it's an actual step taken to prevent wrong site surgeries.
That was basically
The anesthesiologist administers drugs through the IV and through a mask over the patient's face. What function should these drugs perform?
Hold on guys, I'll come back when I make my choice. I've got one right guys.
Great.
And it's
Good work.
yes! Only got
After
one
the
wrong.
patient is unconscious, and before the first incision is made, we need to establish a sterile field around the surgical area.
Oh,
A series of sterile drapes isolates the surgical field from the rest of the patient's body. A tourniquet is applied to cut off blood flow, which allows a clearer view of the surgical field, limit the chance of bacterial
so
infection.
I just bring it up so you don't see half of that guy's face. Get a sponge, and I've got to put it in this black stuff. Honestly, this is what they do inside the hospital. My brother broke his ankle. Called a beta
Betadine
line.
scrub is applied 2 more times, followed by the final arrangement of sterile drapes.
Not
Why do you
around
think knee
standing.
surgery involves so many drapes? Nope. Good work. Use the sterile marker to draw the location for our incision. And don't forget to mark the perpendicular lines too. Typically, the incision line is 6 to 7 inches long.
That's what I like about
What
it.
purpose do you think the perpendicular lines serve? Nope.
Oh no, it wouldn't be that at all.
No. Outstanding. Now for the incision. Take the scalpel and cut the skin following your markings.
This is where it gets a little bit violent.
Let's use the Bovie pencil to cauterize the veins. This will help decrease blood flow into the surgical field. The rake retractors fold the skin and tissue out of the way, exposing our patient's knee. To operate, we need the patient's knee elevated and bent so the bones are fully exposed.
So I need to do a 90-degree angle.
Now the leg is at the proper angle. Use the rongeur to remove the anterior cruciate ligament, or ACL, the meniscus, and any bone spurs that may be lurking about.
Well, I love this part. I mean, I remember playing this quite a few years back. Just basically align the knee sort of thing and just like sort it out.
Are you a good sculptor? It's time to shape the femur, tibia, and patella so the new knee components fit properly. A hole must be drilled inside the femur to set up the distal femoral cutting jig and alignment device.
Warning headphone users. Oh, it's not that loud. I forgot to turn my
The
volume
jig
down.
is put into position and helps ensure that the
So it's
cuts
not a
made to
warning
the
for you
bone
guys.
are exactly what are needed. Now hammer in the pins to hold the jig.
Get the metal mallet.
now remove the alignment device. The pins will hold the jig firmly in place. Now for some real bone shaping. Use the bone saw to cut the bone so it is prepared for the new femoral component. Another cutting jig, along with the bone saw, allows us to finish shaping the femur. Let's move on and shape the tibia. The tibial cutting jig is aligned with the big toe and the highest point of the tibia. This will ensure the leg is properly aligned after surgery. Secure the jig in place with more pins. Use the bone saw to cut off the top of the tibia and prepare it for the new tibial components. Now we'll use the patellar cutting jig and bone saw to remove the back of our patient's patella.
Patella jig, bone saw.
Holes in the tibia and patella are drilled and chiseled out, which will enable the new components to attach properly. Time to place the trial components. First, attach the femoral trial component.
Got it.
Attach the metal tray trial component to the tibia. Insert the plastic trial spacer into the metal tray component. Lastly, attach the patellar trial component. Why do you think the two tibial components are inserted separately instead of as one unit? No. Fantastic. Conduct a range of motion tests to assure proper knee alignment and successful prosthetic fit. Typically, a normal range of motion allows the leg to move from 0 to 130 degrees. How does our patient's range of motion look?
Bad.
Knees aren't meant to bend sideways, so it's important to determine whether there is a gap or space between the femoral and tibial components. There's no noticeable gap, so this knee is a good fit. Why do you think there are so many steps taken to ensure proper alignment? We've tested the trial components. Now let's remove them and prepare for the permanent components by applying a special cement compound that binds metal and plastic to bone. The scrub technician has mixed up a batch of cement for you to use. With the cement in place, the final components are permanently attached to the knee. Any excess cement will be scraped off and thrown away. Lay the leg flat on the table so the new knee components put pressure on each other. This allows the bone and components to bond with the cement. The cement can take anywhere from 10 to 15 minutes to harden.
It won't take that long, guys.
We perform our range of motion tests one final time. Our patient's new knee is looking good. Let's close up the incision. First, suture the deep tissue and fat layers back together. For closing the surface incision, you have a choice between the stapler and the suture.
I'll do the suture. For one, it's not only the safest, and two, you won't have to go to the hospital just to get them taken out, and they're very irritating to take out. My friend had to get stapled up. I'll show you. He cut his arm from like his left shoulder all the way down like that to there. So it wasn't that bad, but it was deep.
What is the primary difference between these two methods of closing the incision? Nope. No. Excellent. You know, we couldn't ask for a better participant. You've done an excellent job. Are you sure this is your first total knee replacement? Our patient will remain in the hospital for 3 days, followed by 3 to 8 weeks of physical therapy. Because of this surgery, our patient will have significantly reduced pain and increased mobility. Before you leave, let's think about the life of the new knee components. What kind of forces do you think the new knee will need to withstand? No. Nope. Nope. Nice job. People average about 5,000 steps per day. Our patient's new prosthetics will withstand a great deal of force, for 36 million steps or more. I'm off to check on another patient while the OR team prepares the room for the next surgery. You've been a great help. See you next time.
Okay, chain. And also, guys, I'll see you next time when I make the videos. I'll be doing this along with Dead Cut, which is sort of a World War One, World War Two sort of surgery, but it's like really violent and there's loads of noise, so probably headphone users warning. But apart from that, I shall see you in the next one. But that was done. Yeah, I'll see you in the next one.